Yes, we are live now. You can go ahead, sir.
Okay, good evening, everybody. I'm sorry for the slight delay. I was just held up with a case, and I think maybe with things getting busier, we may have to change the timings from next week. Today, we are going to discuss on congenital talipes equinovarus, and basically, I'm going to go through some of the etiology, pathogenesis, and the Ponseti method, essentially. And maybe we'll take the relapsed and secondary corrections at another lecture because it'll be too much to cover in one day. Okay, so this is some of these slides are from Dr. Shafiq Pirani, who was in one of the posicons some years ago. Basically, William Hazlitt, way back in 1778, said that when a thing ceases to be a subject of controversy, it ceases to be a subject of interest. And the fact that there's still so much interest. क्या हुआ?
सर आपने स्क्रीन शेयर नहीं किया है.
Oh, sorry. बताया नहीं पहले. Sorry. What am I doing? Okay, sorry about that. This is what happens when you're rushing things. Okay, so it's going to be about clubfoot deformity, and it's interesting that the earliest, it's okay now, na? Janki, it's okay now?
Yes, sir.
Okay, sure. So the first is the art was also not neglected it altogether. And this is an interesting painting which is there in the Louvre, which is one of the biggest museums in the world in Paris. And it's called The Clubfoot by Jose Rivera. Interestingly, if you look carefully at this painting, it's actually not a clubfoot deformity because he's got most likely right-sided spastic hemiparesis due to cerebral palsy, but it's labeled as a clubfoot in that painting. Now, the incidence world over is around 1 to 2 per 1,000 live births, with an increased incidence in Maoris, Polynesians, African blacks, and Hawaiians, and probably less in the Orientals, that means in the Far East. Probably more common in India, but we don't have very accurate figures as yet. The male and female preponderance is for 2 to 3 males per 1 female, and it's more or less equally unilateral or bilateral. Now, when we come to the etiology of clubfoot, there are a number of reasons given for the etiology or the cause of clubfoot, starting with mechanical factors in utero, neuromuscular defects, primary germ blast defect, arrested embryonal defect, heredity and environment combined. And just go through these points briefly. I think the mechanical factors in utero have been held responsible from the time of Hippocrates to Galen to Dennis Brown as late as 1936, or even as late as 1964. Wynne Davis still felt this was one of the factors responsible. Neuromuscular defect is another sort of very commonly thought of reason for having this problem, and various authors, including Isaacs, Handelsman, Attenborough, Lickblow, Orefino, Ionesco, Willie et al., and Irani have sort of thought that neuromuscular defect may be the cause of this deformity. And more recent work has shown that the calf muscles especially tend to be fibrotic and smaller in size than the opposite normal limb, which they have shown in MRI studies. One of the other thoughts is that there's some arrested development in the intrauterine period. Okay, and this is supported by various authors, including Hutter and Volkmann, Bohm, but opposed by others. Victoria Diaz in 1973 showed that growth spurts occurred in the development of the embryonic feet. You had a stage which was called the fibula phase, where the fibula grew, and the second stage where the tibia grew. And it was felt that maybe the fibula phase happened, and then for some reason the growth was arrested in the tibial phase, leading to the deformity. But again, we don't have much adequate sort of proof of these or evidence of these etiologic causes. The other thing is some extrauterine factor like teratogenic agents causing problems, and Duraiswamy, who's one of our leading lights from India in orthopedic surgery in the past, actually did his thesis on this for the MCH, where he showed that with injection of insulin, you could develop deformities in a chick embryo. So similarly, other people felt that some arrested fetal development may be caused because Turco showed an increased incidence in home for unwed mothers. So a lot of them may have been people who took were involved with substance abuse. Again, heredity factors are definitely responsible, because if you look at some of the studies, there's definitely more common in identical twins and also in zygotic twins compared to the general population. But there is still no recognizable pattern of inheritance to suggest what particular gene is involved in this. So it's probably a polygenic multifactorial trait. The other reason is that Rebeck favored the heredity cause, saying that deformity can be explained by segregation of a single Mendelian gene and other minor genes or non-genetic contributors. So multiple sort of people have thought that hereditary factors do play a role. And probably the general belief today is that it's a combination of hereditary and environmental factors which lead to the deformity being there in a particular child. Again, the pathoanatomy has gone through various phases, where Scarpa was the first to describe the pathological anatomy of the clubfoot and described it as a congenital dislocation of the astragalocalcaneus scaphoid complex. Okay, so this was terms they used for the basically for the talar navicular complex, which was the primary area that seemed to be involved. Okay, so multiple other reasons have been given, including fibrosis of muscles, various tendons, etc. But it's interesting how, if once we come to the Ponseti method and the work of Ponseti, and we'll come to that later, we'll shed some light on what the exact pathology is in these club feet. So I think in your clinical assessment, you start with a history. So any child, you need to look at the birth history, the maternal history as to whether there have been any medication done during the pregnancy. You need to do a proper general examination and also a careful local examination of the foot. So rule out any spinal abnormalities, any congenital dislocation or dysplasia of the hip, which can occur along with it, and also rule out things like spina bifida, etc., that may be possible, may also be there. Okay. So in the general examination, you check out for things like spinal dysraphism, hip dysplasias, other congenital anomalies, cerebral palsy, and other neuromuscular disorders, as I mentioned. Locally, look for the severity of the deformity and the rigidity. So some deformities may look very bad, but when you feel them or try to correct them, they may not be as rigid, and vice versa. And again, you need to look at the heel and skin creases, and we're going to come to those in little more detail later. Again, look for any bony prominences, scars of previous surgery, velocities, the calf circumference, and limb length discrepancies. Okay, so all these things need to be looked at in your clinical examination. Now, X-rays earlier on was we used to really look at the X-rays carefully and measure all these angles. I think with today's with the Ponseti treatment, X-rays in the primary or the idiopathic clubfoot don't really play a role in the initial assessment. You generally would do X-rays if they've come later with relapsed clubfoot, or you're suspecting some syndromic clubfoot, etc., then you would do X-rays. Today, ultrasound may help you in looking at how supple the foot is. So the reducibility of the clubfoot can be seen on good ultrasound scans if you have people who can do it for you. Now, the simplest classification, I'm not going to go into details of the other classifications, is to divide them into 3 groups. One is the idiopathic clubfoot, which is what we're going to talk about. Then you can have neurogenic clubfoot, where there's some neurological disorder. You can get that with spina bifida, with cerebral palsy. Here we still see some of the older poliomyelitis patients who have this, can have a deformity which is similar. And again, you have the syndromic clubfoot, which is the classical one is the arthrogryposis multiplex congenita, and these can be very difficult to treat and so should be separated from the idiopathic group. Now, Ponseti in his book also described the various definitions for the various deformities and sort of movements of the foot. And he defined adduction as a movement in which the tarsal bone, the distal part of this bone moves towards the median plane. Okay, so adduction is when the distal part of the foot moves towards the median plane, and abduction is in the opposite direction. Similarly, flexion of movement of the tarsal bone is where the distal part of that bone moves in a plantar direction, and extension is when it moves in the opposite direction. That means towards the dorsal side. Inversion is where the tarsal bone is where the undersurface of the bone moves towards the medial plane. So this is different from adduction, where the forefoot moves towards the medial plane. Here the undersurface of the foot moves towards the median plane, and eversion is the opposite movement. And supination is a combined movement of adduction, flexion, and inversion, while pronation is a combined movement of abduction, extension, and eversion. So it's important to understand what is meant by these terms, especially with the Ponseti treatment. The heel varus is inversion and adduction of the calcaneum, and heel valgus is eversion and abduction of the calcaneum. Okay. Similarly, forefoot supination is inversion and adduction of the forefoot. Forefoot pronation is eversion and abduction of the forefoot. Equinus refers to an increased degree of plantar flexion of the foot. Cavus refers to an increased height of the vault of the foot. Okay, so it's a cavus deformity. So it's interesting that Ponseti sort of moved from Europe to the US. As you all know, or should know, that he was Jewish and was actually one of the people who was displaced during the Nazi uprising and ended up in the US. And in 1941, he arrived in the Iowa Medical School to complete his orthopedic training. Okay, now interestingly, different methods were being used by members of the staff, and one of the famous surgeons there was Dr. Arthur Steindler. The general method was to use the Brockman release, which is like something similar to a sort of quite a radical posteromedial release of the foot. Okay, and what Ponseti found that in the follow-ups, a lot of these children ended up with a lot of scarring, stiffness, and weakness of the muscles of the foot, and in long term they had other problems like pain and deformities involving a part of the foot. And he felt that this is not really the best way to treat them. The kite method was the method to generally correct club feet when you were using plaster techniques or conservative methods, but was not so successful, and a lot of people ended up in surgery. So Ponseti, in his sort of readings, found some of the work of Robert Jones, who you all must be aware of, who in 1923 wrote that he had never met with a case of clubfoot where the treatment had been started in the first week of life, where the deformity could not be completely rectified by manipulation and retention in 2 months. So Robert Jones had a method by which he felt that he could correct all club feet provided they came reasonably early with conservative treatment with manipulation and retention in casts. So Ponseti was sort of intrigued by this, but this was a result which was not repeated by anyone else. And Ponseti felt that this failure was partly due to poor understanding of the functional anatomy of the normal foot and the club foot. Okay. So then he started looking into it in more details. He studied the pathological anatomy of the club foot. He dissected several normal feet. These were in fetuses, and also was able to find 3 club feet in stillborn babies and 2 club feet in 17 of a 17-week aborted fetus. So he had these 5 club feet and which he had access to dissect, and then he had the normal feet, of course, where the child had died for some reason or the other early in life. Okay, so then he started studying all these feet very carefully in terms of the muscles, the kinematics, the movement of the various joints, and actually looked at them under radiography. He obtained serial cross sections through various parts of the foot and trained his fingers to palpate the joints of both feet, both in normal feet and club feet. So he sort of trained himself to be able to palpate the joints properly, and then over a period of time was able to come to a uniform type of treatment by 1948. Okay, so he felt by then that he was convinced that he had an answer. And however, initially he found that even with this method, relapses were frequent. And then that was when he added the tenotomy to the treatment. Okay, so what are the principles of the Ponseti correction? One is that all components of the deformity have to be corrected simultaneously, with the exception of equinus, which should be corrected last. The cavus results from pronation of the forefoot in relation to the hindfoot. So remember this, and therefore this is the first part of the Ponseti correction, where you supinate to the forefoot so that you bring it in line with the hindfoot. Okay, so the first cast which you do in a Ponseti is just supinating of the forefoot, and you do that by elevating the head of the first metatarsal. Okay, so once you get that alignment of the foot right in relation to the forefoot and the hindfoot, then you start gently abducting the foot under the talus. So the talus, head of the talus is the fulcrum against which you will abduct the foot. Okay, and what he found that the heel varus and foot supination will correct when the entire foot is completely abducted and with maximal and external rotation under the talus. Okay, you should never try to evert the foot. You keep it in the position aligned with the hind foot, and then sort of abduct the foot, and the rest of the things will correct themselves. Okay, and lastly, the equinus had to be corrected by dorsiflexing the foot, and this he found that more often than not needed a tendo-Achilles stenotomy. Okay, and it was interesting that Ponseti was doing this method all these years. They published a couple of papers showing excellent results in close to 70, 80, 90% of the cases. They added tibialis anterior transfer to the ones who relapsed. Rather than doing any soft tissue releases, they did a tibialis anterior transfer at the age of 4, above the age of 4, between 4 and 5 to 6, usually, especially for children who were tending to adduct their foot, especially while walking. But when you did the tibialis anterior transfer, it was important that the foot was corrected. It was interesting that it was not till this third paper that they came out where uh, Cooper and Yates actually looked at the results of the club foot in terms of the functional result of patients who had long term. So this was a 30-year follow-up of these patients, and then compared it with patients waiting in an ophthalmology OPD clinic. Okay, so they looked at feet in these group of patients waiting in the ophthalmology clinic and compared it to the patients they had treated with the Ponseti method. And then they found that if you compared the results of these two in terms of the functional results, when you talk about excellent, good, and poor, even people who did not have club fit did not all have excellent results in the scores. And when they compared the two, it was very similar. So with the Ponseti treatment, you're getting very close to a normal functional foot over the period, over a long-term period. And this really convinced people. And then from the 90s, gradually the Ponseti treatment became more and more popular. And today is really the more or less almost accepted way of treating worldwide. There are some other methods of manipulation, the French method where they use multiple stretching with taping rather than casting. They also do what they call a la carte surgery. That means do whatever releases are absolutely necessary at the end of the stretching. So that's another group, but by and large, world over, the Ponseti treatment is definitely the one that is most often used. Okay, so now coming to the clubfoot treatment using the Ponseti method, I think these are the deformities you need to be aware of. They call it cave, which is cavus, forefoot adduction, hindfoot varus, and equinus. Okay, so if you look at the foot, these are the deformities. You can see the cavus here. You can see the equinus here. You can see the varus of the heel here and the adduction of the forefoot here. So these are the deformities that you need to deal with. And if you look at them, compare that with the clubfoot this is a dissection specimen of a neonate with clubfoot who was a stillborn child. And you can see again all these deformities, how the talar head subluxes out laterally while the navicular is dislocated off to the medial side. And this is the prominence that you feel on the lateral side. And this is the models that the Ponseti group have developed to teach their method of treatment. And what they show is that as you abduct the foot with the fulcrum as the head of the talus, the entire foot corrects itself, and actually the hind foot also derotates out of the deformed position. Okay, so in the pathological specimens, they found all these various things. That there's a plantar flex first metatarsal. There was severe tibiotalar plantar flexion. There was adducted and inverted calcaneum, and the medial displacement of navicular and cuboid. Distal calcaneal articular surface was adducted, and the medial talar neck, there was a medial talar neck inclination. So although this was coming out this way, the inclination was towards the medial side. So the method of correcting this deformity, so the cavus is, as I mentioned, corrected by elevation of the first metatarsal. So by supinating the foot, by elevating the first metatarsal head, you corrected the cavus, and the adductus by abduction of the midfoot, varus by everting the calcaneum. And this happened automatically as you were abducting the foot. And equinus is by dorsiflexion, which was done as you were correcting it gradually, and then eventually by a tenotomy. Okay, so the method involves first manipulating the foot for some time. So it's not that you go straight away and cast the foot. You need to spend about 5 to 10 minutes gently manipulating the foot in the direction that we talked about. And once you've done that, you hold it in the corrected position and put on your cast. Okay, so remember, this is the manipulating before the casting is an important part of the Ponseti technique. And I find a lot of people who just dive straight into the cast and then they try to correct the deformity with the cast, which then leads to other problems with swelling and the cast being tight or sores taking place. So the idea is that you get your correction, wait for some time, let the child settle down, and then do your cast. And these are done all as OPD procedures without anesthesia. I remember initially when I started my orthopedic training, we used to do the clubfoot casts under anesthesia, and now we try to avoid anesthesia in children as much as possible. So talking about the cavus correction, this is what you do. This is showed in the model. This is the plantar surface, and you can see the thumb elevating the head of the first metatarsal. Okay, so in clinical, this is in the model again, elevating the head of the first metatarsal. And this is in a patient, you can see how the very severe cavus here. And the moment you elevate the head of the first metatarsal and supinate the forefoot, you can see how the cavus is disappearing. Okay, so this shows you that by lifting this up and supinating the forefoot, you're actually getting rid of the cavus. Of course, in the very neglected foot, these become adherent cords, and it's a different situation. But in the young patient, generally by doing that in a child, this is possible to correct the cavus. Okay, and then the next step is the abduction. Okay, so you correct the forefoot adduction and heel varus by abducting the foot with the fulcrum at the head of the talus. Okay, and as you do this, you can see how the forefoot is correcting and derotating itself, and also the hind foot also will correct itself, which we'll show you. Okay, now the whole foot is abducted in the talus. The thumb is not on the head, is on the head of the talus, not on the calcaneum. Okay, so if you saw what kite used to do, the thumb used to be somewhere over the calcaneo-cuboid joint or calcaneum, not over the head of the talus. And you leave the heel. Okay, so don't hold the heel as you're abducting it. So that allows the derotation of the calcaneum. Okay, so you may be touching the heel, but you're not holding the heel when you're doing this abduction maneuver. Okay, and eventually by the time your last cast is done, you should almost be at 60 to 70 degrees of abduction of the foot. Never evert the foot. So all the time the foot is kept in that supinated position, and gradually as it gets reduced, the navicular will move away from the medial malleolus and cover the head of the talus. Okay, so again you can see how with the manipulation the foots improve, and here again you can see that the varus of the heel and the sort of cavus and the deformity that you see on the heel, as you abduct the forefoot, this derotates and corrects itself. Okay, so you can see how this is in varus, and here as you abduct the forefoot, this gets corrected because of the kinematics of the joints. And as I mentioned again, the last cast before tenotomy, the foot is rotated 60 to 70 degrees with respect to the thigh. Okay, so and these are always above knee casts. The reason for this is that you can hold the position better, and also in a small child, especially a chubby child, if you keep it below knee casts, the child will come back next day with the parents holding the cast in their hands. Okay, so again, these are models from the Ponseti sort of school, showing the various stages of the foot as it's being corrected with the casting, and the shells of the cast during the treatment. Okay, so that's how the foot should look like in the cast over the correcting period. Okay, the last bit is the Ponseti thing is the tenotomy. Okay, this is a complete section of the tendon not lengthening. Okay, now in a small child, this tendon will grow back, even possibly in adults. Okay, and this is based on, I mean, this is what the legend has. I don't know how far this is absolutely true, but Ponseti noticed it in the prison camps for the Jewish folks during the Nazi times and various parts of Eastern Europe and Europe, where they would cut off the tendoachilles of the prisoners so that they could not jump over the walls. And apparently within 4 to 6 weeks, they would be again ready to do all the physical activity and be perfectly okay. And sometimes they had to end up cutting the tendons again. So just showed that even in an adult, probably the TA can go back. This is in a patient we had earlier done a tenotomy and later on had to do a release, posterior release, and you can see how the tendon, there's some scarring, but the tendon has completely regenerated. Okay, so this is what it's based on. Okay. Now, some of the differences between Kite and Ponseti was that Kite believed in correcting each sort of component of the clubfoot deformity separately and in order. And therefore, it took many more casts and you probably did not get the best correction that you needed. While Ponseti believed in the correction of all the components apart from the equinus simultaneously. And this was based on his studies on the foot, which showed that the moment you abducted the forefoot, the other parts of the foot, as long as you kept the fulcrum on the head of the talus, the other parts would correct itself. He also cautioned against exacerbating cavus by pronating the foot. So the natural instinct for a clubfoot, which is in equinovarus, is to try and abduct or pronate the forefoot to correct it. And that is something you have to avoid doing because you will exacerbate the cavus, because the forefoot is actually relatively already in pronation compared to the hindfoot. Okay, and so what Ponseti talked about and said that it took 40 years for the orthopedic thumb to move a centimeter, that is from the calcaneum to the head of the talus. Okay, so this is what Ponseti used to joke about, saying that 40 years for the orthopedic thumb to move 1 centimeter. So what we have found is that with the Ponseti technique, the contracted soft tissue yields to stretching, would yield further to allow more correction by cast immobilization. And he felt that if you did daily manipulations, you would get more inflammation. So the idea was that you manipulated it, kept it in a cast, waited for things to settle down, and then manipulated it again. And then at the end of the correction, he believed very strongly, rather than use AFOs or various types, to use this modified Dennis Brown shoe, which he called the Steenbeck abduction brace. And this was to be used 3 months full time. That means day, night, except when you were washing, etc. After that, now it's 4 years nighttime use. The bar is as wide as the shoulders. Okay, so the spread of the bar between the 2 feet is the width of the shoulder of the child. The affected foot is externally rotated to 70 degrees. If one side is normal, that is kept at about 30 degrees. What they found in their studies is that failure to comply with the use of the braces was the most common cause of recurrences. Okay, and they also had a low posterior cut and a peephole to make sure that the foot was well fitted, and a strap to hold the foot down. So these were the components of the brace. And they also showed that if you had a low heel cut, it was better than a high heel cut, because if your heel was very high, when you it would dig into the TA and then cause the foot to come off the brace and go into equinus. Okay, so that was the reason they felt that they should not extend beyond this height in the foot. Okay, so these are the various important things in the brace that you need to know about. The other thing was when you are correcting the foot, you needed to find out some way of assessing how much correction you want. There were some classifications, etc. But in terms of scoring the foot, they came out with Shafiq Pirani and his group came out with this method of the Pirani score, where points were given to the hindfoot and the midfoot. The points, there were 3 different things that they looked at in each of these, and each was given a score of 0, 0.5 or 1. So a total score of 6. So you looked in the midfoot, you looked at the lateral border, the medial crease, and the talar head coverage. Okay, so if the talar head was completely uncovered, it would be the maximum deformity. Okay, so it would get a score of 1. If it was well covered, then it would be 0, and similarly, so 0, 0.5 or 1, depending on how deformed it was. So 6 was the maximum score for maximum deformity, and in the posterior part of the hind foot, you look at the posterior crease, the equinus, how much equinus there was, whether you could dorsiflex it above neutral to neutral or nowhere near neutral, and the empty heel sign. So these were the 6 things that you looked at and scored them. And also during each cast, you checked the scores to see how much correction you were getting, and you really had to get the score down to 1 ideally before you could plan your tenotomy. Okay, so you really needed to get this complete score, total score down to, so the maximum you can have a partially empty heel and not so bad posterior crease, and then you could do your tenotomy to get your full correction. Okay, so Ponseti technique is really a well-conducted orthopedic treatment based on sound understanding of the functional anatomy of the foot and on the biological response of young connective tissue and bone to changes in direction of mechanical stimuli. And you can almost eliminate, according to Ponseti, all these deformities or reduce it to a great extent using this method in almost all the club feet. Now, when it comes to treatment of relapsed clubfoot, I think we're going to look at that separately. I think initially, we all know there are multiple surgical procedures, bony corrections, combined bony and soft tissue corrections, distraction techniques, distractions combined with osteotomies, etc. But today, even in the relapsed foot, as long as it's not had multiple surgeries, we would try to repeat the Ponseti technique. Maybe in addition do a tibialis anterior transfer and sometimes even a plantar fascia there to get correction. Okay, so I think those are things we'll look into next time. The various reasons for relapses, how they relapse, what you can do for relapses. But today this is enough. I'll stop here and we can take questions on this. Okay.
Yes, sir.
Okay.
Sir, Amit has few questions. Actually, his mic is not working, so he asked me to ask.
Sure. Yeah.
Sir, he want to know, does presence of DDH affect or change the usual protocol mentioned by Ponseti?
Not really, no.
In dysplastic hips, developmental
No, because see,
dysplasia of hip,
so most dysplastic
the
hips.
protocol is same.
Yeah, so in dysplastic hips, when initial treatment is what?
Sorry, sir, I'm not able to hear you.
So in a dysplastic hip, what is your initial treatment going to be?
Yeah.
So when you get them very young, you're not going to rush into surgery for that, are you? Or you're not going to rush into putting them in a plaster. So the initial treatment would be a Pavlik harness or a brace, double nappies initially.
Yes, sir.
Okay.
Yes, sir.
And in that period, your Ponseti treatment should be over. Yeah. Okay. So your Ponseti treatment starts nowadays as soon as the child is okay. Huh? So if you just wait to make sure that the child is thriving, the mother gets used to feeding the child, etc. And then in the first week itself, we start the casting. And hopefully by the 5th or 6th week, we finished with the treatment, another 3 weeks in the cast, and then they go on to bracing. So that should not, and if you're using the sort of abduction braces, it's good for your hips also, okay? Or if you have a dysplastic hip, abduction brace is actually going to be good for your hips also. Okay?
Yes, sir. Sir, other question he has asked, chances of recurring if tenotomy not done. Is tenotomy needed in all? Yeah,
so not all, but so this is what Ponseti found is that when they did not do tenotomies, the recurrent rates were higher. The idea was to try and get about 20 degrees of dorsiflexion at the time of the tenotomy. Okay. and keep stretching the TA, because if you didn't, then over a period of time, it would lead to recurrence. Okay. So I think you don't need it in all of them, but probably close to 90% of the children will need a tenotomy. Of course, there's not everyone believes in this. There are some people who want to avoid tenotomies, saying that even a tenotomy of the TA causes some functional loss, but the studies have showed that they can do almost everything which a person with a tenotomy can do. Okay, the jump distance, they've looked at various studies to see the strength of the TA, and it comes back to pretty close to normal.
Okay. He also want to know the incidence of DDH with CTEV. Probably it is a theoretical question. You can check.
Yeah, I think it's so any deformity, congenital deformity, there is some chance that there could be other deformities. Overall, the incidence is similar, 1 in 1,000 world over. But if you look in India, probably it's more common, the clubfoot deformity, than DDH. At least in our practice, we see many more club feet than we see DDH. Having said that, we may be missing some early. But having said that, we don't see that many neglected cases of DDH as we see of clubfoot either.
Yes, sir. And probably for packing disorder, both comes, so the incidence is quite common. So, sir, for other DNBs, if you have any question, please ask.
I think Gautam is still stuck in a case.
Okay, sir.
So he's not been able to get it.
Okay, sir. And one question, what usually asked in the exam, sir, is that till what age we can do that Ponseti casting, sir?
Okay, so that's what we gave. So initially it was first year, then second year, and now even up to 10 years, and people do it even later. Okay, so now there are enough papers about doing it up to the age of 10 years. What is slightly different is obviously this is not necessarily in patients who had multiple surgeries and syndromic feet. Okay. But in a standard idiopathic clubfoot, either which has not had treatment or has had the Ponseti treatment earlier, but no major soft tissue releases, you can actually repeat the Ponseti treatment. Again, you have to discuss this with the parents and the child at that stage as they get older, because ideally you should give them above knee casts, at least in the initial period. You can change to a below knee cast once you've got the foot somewhat corrected so that the child can walk on it better. But if it's a really deformed foot, the long leg cast is better, but you need not. I think recently there was a symposium, Pediatric Orthopedic Society symposium on relapsed clubfoot, and Jose Morcunde, who worked closely with Ponseti for many years, was there. And what they do is they maybe don't extend it right up to the groin, just extend it up just above the knee. And in the very not so very bad deformities, they could maybe just do a below knee cast. Okay, but for the severe deformities, you'll still need to start with above knee cast. And this in an older child becomes difficult to keep the child in sort of quiet with all that. You do tenotomies, you may have to add tibialis anterior transfer sometimes. Okay, and as I mentioned earlier, that sometimes you may have to do a fasciotomy for the cavus, plantar fasciotomy. But the idea is to try and avoid soft tissue releases, capsulotomies, etc. Okay, now we went through a phase when in my early surgical orthopedic practice, we did so many soft tissue releases. Okay, almost every day in our list we used to have a soft tissue release. But now it's very rare that we would do a soft tissue release, and certainly not as the primary treatment in a clubfoot.
Okay. Sir, other question what they used to ask, sir, is the difference between kites and Ponseti, and one method like French taping. They used to ask.
Yeah, so I mentioned these things. So I had some slides on the French thing method, but because it was getting a bit long. I left it out. I don't know whether I still have it somewhere in the...
That one they used to do it daily, sir, for that.
Yeah, so
kidney.
that is for the this thing technique, they do daily manipulation and taping. Okay.
Okay, sir.
They would do that. I'll just show you what the. Let me see if I can take it out quickly. From an old talk somewhere. Okay, you can ask any other questions in the meanwhile.
Sir, usually after the first cast, sir, when we do the correction of cavus, which was not in the kites method, usually the deformity is exaggerated, sir. So that is the reason sometimes we lose our patients also.
Well, if you explain it to them beforehand, then it's never a problem. Yeah. Okay, you understand?
Yes, sir.
I think the problem is you're not explaining it to them properly. Okay, so let me see if I can just get through those few slides while we are.
One more question. Okay, sir.
Yeah, I'll just get through this. So
yes, sir. In between, I just asked.
Okay, so this is the French technique. Okay, daily corrective manipulation. This is usually done by trained physiotherapists. They strap it. Sometimes they put a rigid foot plate along with it. Okay. So they reported good results in 50% which increased to 88% with subsequent complementary surgery. Okay. So what they meant by complementary surgery is a la carte surgery. So they would do tenotomies. They would also do some soft tissue releases, etc. as part of it. Okay. Then they also did this active solicitation of peroneal muscle function. I think this is an important part even with the Ponseti technique because the peronei tend to be weak. So to try and get the peroneal muscles to work is a good idea, whatever method of treatment you did. But in that, only 50% did not need surgery. Okay. So that is still quite a high rate of surgery. And then Di Meglio added this use of a multiplanar continuous passive motion machine. So now this is very difficult in a very small child, but they had the facilities to do it and they could reduce the number of surgeries to 28%. Okay. And they also then went on to do home treatments, etc., which was possible for them to do, but may not be possible in our setup. Okay. So that was basically the French treatment.
And regarding one more thing, sir, you have explained about the X-ray, sir, that in all the cases it is not needed, only in the syndromic or secondary. So during the follow-up also, sir, we should take X-ray in those cases, sir?
Not really. So now we've stopped doing X-rays for most of them,
Okay,
unless they get a problem. Okay, so if they are normal, they are developing normally, there's no recurrence, etc. We don't do X-rays every visit. I remember early on we used to do X-rays every 3 months, 6 months, then every year. Now we just stopped doing that.
Okay, sir. And sir, in multiple congenital contracture, which was considered as contraindication before, is it like so that we can do the Ponseti method of treatment in those cases also?
So even in arthrogryposis, okay, that's the most common one.
Yeah.
So you can, especially if you get them really early, okay, you can do that. Of course, the risk of recurrence will be higher. It may take more casts to correct. Okay.
Yes.
And these patients also have other problems. Okay. It's not just that joint. So the knee joint, hip joint. So they never have the same functional results as you would get with the idiopathic clubfoot.
Sir,
but able to correct the deformities in a significant percentage of the cases.
Okay, sir. Sir, Amit want to know that what about the use of JES in older child, like as after correcting as much deformity as possible via cast, can we apply JES?
Yeah, for sure. I mean, like we still use it, but So JES is another way of distraction correction. Huh? Could use Elizarov. But even with the JES, we kind of use the Ponseti technique by stretching out the soft tissue and then every 2 weeks actually repositioning the foot with your talus, head of the talus as the fulcrum for your rotation of the foot. Okay, so you can combine JES and Elizarov techniques with the Ponseti concept of the head of talus being the fulcrum of the deformity. Huh?
Sir, one more question that I think.
But again, so let's put it this way. 10 years ago, 15 years ago, any child who came in that age group by 5 to 6, 7, who had a recurrent deformity, we would probably think of JES or surgery. Huh? Now today, we will still think of going through the steps of Ponseti and then seeing the response before deciding on doing anything more.
Sir, that recurrence and relapse is same, sir? Is it synonym?
There is, so these definitions vary with who's defining them, okay? So Ponseti has got a set of definitions. Different people have different definitions. Basically, one is resistant clubfoot, one is relapsed. So it means it's got corrected and then the deformity has recurred, while resistant is one that has never got corrected in spite of treatment. Okay? And neglected is one that has not had treatment. I think this is the ones that are followed now. But I think recurrence and relapse are, it's sort of just.
Sir,
good evening.
Yeah.
My question is related to the treatment aspect actually. So in a child like of near 5 years of age, how do you decide the treatment between a lateral closing, medial opening wedge, I mean the lateral column shortening versus just application, sir?
Okay, so I think you have to look at 2 or 3 things. One is what treatment he's had before. Okay? So if he's just had a Ponseti treatment before, I would start with Ponseti again. Okay,
Right.
even in okay.
Yes, sir.
Now, once they've got bony deformity, okay, so you're going to look at, so if they, at a certain stage, once they've already had surgery, they've already had soft tissue releases, then only would I think of any of these other methods of treatment today. Okay, now how do you differentiate between JES and doing a lateral column lengthening, shortening and medial column lengthening? I think this is a matter of choice. I think early on we would just use JES. Today we've started doing a more of these sort of small bony procedures because it's quicker. It's over in one shot rather than having to take a lot of time doing it. It's something you have to discuss with the parents, etc. I think all of them address more or less the same group of feet as far as I'm concerned. But one thing is there that your equinus should be corrected before you do any of these procedures. Okay. So if you still have equinus, then doing lateral column lengthening, etc., is not of any use. Lateral column shortening and medial column lengthening.
Right.
Sir, about the last thing, like correction of equinus. So after tenotomy, we used to put a little more dorsiflexion than the normal. Why it is so, sir? Before the last cast. When we are putting the last cast, sir, it is about 10 to 20 degree dorsiflexion in that one.
Yeah. Yeah.
So for why that is so, sir? It's more than 10
because your normal foot goes into dorsiflexion. It doesn't stop at neutral. Huh? So you want to get dorsiflexion. If you want the child to be able to squat and do things, you want to get dorsiflexion. Okay.
And one more thing, sir, like when you say that,
and if you can get good dorsiflexion, again, it also helps in making sure you don't get recurrences.
Okay, sir. And so for that one, sir, when we say that we should start the treatment as early as possible, and we advise after the birth that to start manipulation. But for the cast, we wait for 1 week. Why it is so, sir?
It won't see. It's not. It's 1 week is not a magic number. Okay, you wait for the child to thrive. Okay, that means some children, when they're born, the first few days they will be very sort of unsettled. They'll be crying all the time. The mother is not started feeding properly. So you wait for the mother and child to bond a little bit before starting the treatment. Okay. There's no hard and fast rule saying that you can't start on first day or second. Secondly, the skin initially can be very tender. You wait about a few days just for the skin to get a little better, so that when you cast it, you don't have problems. But by 1 week, usually you can do it.
Do we have any contraindication for ponseti?
If you don't know how to do it, you shouldn't be doing it unless you're trained to do it. Okay.
Okay, sir. Okay, sir. So I think.
I mean, otherwise, why should you have a contraindication to it? I mean, there may be things which will not work. Okay, so if it's a 20-year-old who's had multiple surgeries, bony surgeries, then you're wasting your time doing it. Still can get, so you won't call it ponseti anymore after that.
Ulcers and soft tissues, like something.
Ulcers per se are not a contraindication for clubfoot. Okay, so when we get these feet who are getting callosities and ulcers in the callosity side, we cast them initially to get them corrected as much as we can. Okay, because and you get it corrected, the callosities heal. Okay, but if you can't correct it, then you have to go on to some other method.
So for ligamentous laxity also we can apply, so if patient is having some ligamentous laxity.
I mean, if he's got a deformity, okay, so if he's got that much laxity, that is, you can dorsiflex the foot and correct it, then you don't do ponseti treatment, you just brace it.
Okay, sir. And also, just one last question about that one, sir. Sometimes after putting the cast, there is overcrowding of toes. To avoid that one, what we can do actually? Sometimes in the initial period, we used to have.
So that is your technique again of casting. So you have to be careful that you don't wrap it around too tight. I usually put my fingers between the cast and the cotton when someone else is doing the cast, to make sure that he doesn't tighten it too much. And you make sure if you keep your metatarsal head elevated, then so it's again when you try to pronate the foot that this problem happens more.
I think most of the questions and everything you have covered. So, so we will have for surgical method sometimes when.
Yeah, we'll have another one on more other relapses and some of the soft tissue releases for whatever role they have today, and some of the other techniques for correction after.
Okay. Thank you so much, sir.
Okay, bye.